All right.
Okay, the question of the day is how many PhDs does it take to start a recording? So I'm Dr. Kim Jones, and I want to welcome everybody for coming. We have a lot of people online. Thank you so much. I'm the Senior Associate Dean for Academic Advancement and Innovation. And on behalf of the School of Nursing Leadership, I'm just delighted to have everyone here for today's event. I'm so proud of the Lillian Carter Center. It was here when I was a student here in 1989, and it just continues to do amazing things. The Farm Worker Program in Moultrie, Georgia, partnerships in Ethiopia, Peru, Bahamas. Our students have so many invaluable opportunities because of the Lillian Carter Center. And I'm proud to say that our school's leadership remains deeply committed to the Lillian Carter Center's global mission, even in challenging times when we're not sure what's going to be funded in global health. We are very committed to global health here at the School of Nursing because preparing globally engaged nurses isn't just important, it's the mission of advancing health equity worldwide. And it's my pleasure to invite Tricia Benson, the Executive Director of the Lillian Carter Center, to share a bit more.
Thank you, Kim, and welcome everybody. Building on what Kim shared about our partnerships, the Lillian Carter Center's mission is to help improve the health of vulnerable populations worldwide through nursing education, research, practice, and policy. The Lillian Carter Center ensures that service learning and social responsibility, as you all know, is infused throughout our curriculum and educational experiences for our students. It's intentional how central to our school how we prepare the next generation of nurse leaders. Over the past 3 years, and I look at Jacob, but over the past 3 years, we've been very intentional on our research arm of our center, and Jacob has done yeoman's work toward that. So our efforts have included careful selection of our international partners, providing resources that incentivize productivity, and creating platforms like today's Global Nursing Research Lecture, which, Yvonne, it's a pleasure to have you here in Atlanta. And we're elevating that innovative scholarship to address pressing global healthcare challenges. So I would now like to invite Jacob, who is a rock star to our program, to come forward and introduce our speaker.
Thank you, Tricia. And thank you all for being here. I want to begin by expressing our deep appreciation for our School of Nursing leadership and the leadership of Tricia Benson at the LCC for their immense support to the global research initiatives that we've been undertaking. As you are aware, most of the schools are actually cutting back on their global investments. We are actually doubling down. We are strategically investing in resources that are going to increase our global footprint and promote nursing research capacity in low and middle income countries where we know that medical research is going on in a big way, but nursing research is actually very, very limited over there. And I want to share a few examples of what we're doing. In the last 1 year alone, 10 of our senior faculty have been investing in workshops to train our counterparts in the Global South to prepare them to be PIs that we can collaborate with when we are doing global research. So we had 12 faculty from 6 universities drawn from 4 countries in Africa. And we've taken through like a whole year grant writing and manuscript writing workshop. And out of that, 5 manuscripts have been published already, with our faculty being senior authors in those publications. And 5 of those faculties are now working on a K43 program application. Actually, Becky was among the faculty who was meeting with them last month. So we meet with them for 90 minutes every month, and then we give them statistical support, one-on-one mentorship, just to make sure that they are ready for big-time collaboration in the near future. We also have a first of its kind. We call it global nursing research catalyst grant. I don't think there is any other school doing it. Even the Hopkins folks are not doing it yet. So this is where we are looking at the most promising ideas in global health. And at the school level, we are providing funding so that these ideas can see the light of the day. And it was interesting because the first time we posted these grants, we had 8 very strong applications, and we funded 3 of them. And all 3 applications, the core ideas for the applications came from our peers in the global south. So this is like the whole idea of decolonizing global research, because a lot of times we sit here in Atlanta, we imagine the problems that people in the global south are facing, and then we go there and tell them like, I want us to do research on cancer, right? But now we are flipping the coin and empowering those people because they know their country is better, their system's better, and we are trying to align our priorities with their healthcare priorities and making sure that we are focusing on problems that are going to get external funding. Also, as part of our Global North initiatives, we've been running quarterly webinars with the University of Sydney in Australia. I know most of you guys have been attending those webinars. And just last month, I had a meeting with the leadership of the School of Nursing at Sydney. And to quote them, they are saying that they have a lot of international partnership, but Emory is their favorite partner. And we are really looking for ways in which we are going to deepen the kind of work we do and collaborations. Today's lecture is yet another initiative where we want to showcase global nursing research excellence. So the people we extend this invitation to are the people that we feel they are thought leaders in global research, and they have a lot of things to offer and for our faculty to learn from. So we hope this will create a space for dialogue, learning, and future collaboration. And we also want you to pay a lot of attention to the way nurses go to different countries, collaborate with different people, and end up with programs that do not require fundraising for them to succeed. External funding is key to sustainability of our global initiatives. So without saying much more, I want to invite one of our PhD students, Ibrahim, to come and introduce our speaker. Thank you, Ibrahim.
Thank you, Dr. Jacob, my advisor, and everybody present here. It is an honor to introduce today's speaker and her presentation, which is titled Advancing Global Cardiometabolic Health Equity in African Descent Populations. Dr. Yvonne Commodore-Mensah is a professor and associate dean for research at Johns Hopkins School of Nursing and director for local and global reciprocal innovation at Johns Hopkins Center for Health Equity. As an internationally recognized cardiovascular nurse epidemiologist, her research bridges continents, addressing cardiovascular health inequities among African populations, both in the United States and in Africa, of which I am an example of her mentorship. Her global work includes serving as principal investigator to addressing healthcare in Africa, which is termed the Adinkra Program, a nurse-led randomized control trial program addressing hypertension in Africa, and then the linked BP and linked hearts program, which are cluster randomized control trials implementing multi-level interventions to enhance hypertension control and chronic condition management in primary care settings here in the United States. Dr. Commodore-Mensah's contributions have earned her fellowships to prestigious organizations, including the American Academy of Nursing, the American Heart Association, and the Preventive Cardiovascular Nurse Association. Her leadership extends beyond borders, serving on the boards of several prestigious organizations, including the Preventive Cardiovascular Nurses Association, in the Greater Baltimore and Maryland area, American Heart Association, then the Horizon Foundation, and Nursing STEM Coalition. As president and co-founder of the Ghanaian Diaspora Nursing Alliance, which I'm very proud to be associated, she works to advance nursing healthcare in Ghana, and she directs Global Cardiovascular Health Equity Lab and co-directs the Cardiometabolic Health Interest Group at Johns Hopkins University. Ladies and gentlemen, please join me welcome our guest today, Dr. Yvonne Commodore-Mensah.
Okay. Good, still morning. Good morning, good afternoon, good evening, wherever you are. Thank you, Ibrahim, for that lovely introduction. I definitely feel the Southern hospitality. It's good to be back home. It feels like home. Many of you in the room knew me when I was an assistant professor here over a decade ago. So it really feels good to be back. Thank you for your leadership. It's wonderful to hear about the work of the Lillian Carter Center and the work that you're doing to continue to advance global health equity. So I'm truly honored to have the opportunity to come back home. So as Ibrahim said, today I'll share briefly my journey and my experiences in terms of advancing global cardiometabolic health equity in African descent populations. But more than anything, I look forward to our dialogue at the end of my lecture. I hope. Okay, so first disclosure. I'm an African in America. Ghana is still in my DNA. I was born in Ghana, so that affects how I look at health equity locally and globally. I came to the US in 2004 and still feel very passionate about advancing health equity here in the US, but also on the continent. And so when you hear about African diaspora populations, the term diaspora does not only apply to Africans, but the point of this slide is to really highlight the fact that there are different African descent populations all over the world. And most of my work has looked at African descent populations in the US, but also on the African continent, but acknowledging that there are Africans from Africa who are all over the world. And in terms of my program of research, in the middle is, the shape of the African continent, but the four circles you see there are the intersections between my different areas of research, immigrant and global health. I always say you don't have to go outside the US to care about global health. Global health is right here in the US. Mobile health technology, I care about how we might use technology as tools to improve cardiometabolic health. Team-based care, acknowledging that there's enough cardiovascular disease to go around, and we need to really expand the way we think about advancing health and training, empowering nurses to do much more than they ever have. And then implementation science. So there's a lot of evidence that exists. How do we actually implement them in real world settings? So those are the four areas. So February is Black History Month. It is also Heart Month, my favorite month in the year. And so we all know that heart disease is the leading cause of death in the US. And we know that in terms of racial and ethnic disparities, Black males and Black females have the highest age-adjusted cardiovascular disease mortality rates. But what explains some of these disparities? We know that there are also disparities in the prevalence of the risk factors for cardiovascular disease. So this is a figure using enhanced data and looking at the concept of life's essential 8 that was developed by the American Heart Association. So it goes from 0 to 100. 100 means better health. So if you look at the bar, you can see the teal color is non-Hispanic Asian Americans who have the best or better cardiovascular health, but you can look at the individual risk factors. We're all struggling with diet, right? Very few Americans consume what will be considered a heart-healthy diet, but for each of the risk factors, you can see these disparities. And what has changed over the past couple of years is how we talk about disparities. Historically, we would say Black people are more likely to have diabetes, hypertension, kidney disease, and just end there. We are evolving in how we describe the root causes of these disparities. It's not biology, it's not race. There are underlying structural determinants that explain these disparities. But my work also focuses on addressing immigration as one of the determinants. So place of birth. Unfortunately, Immigrant populations in the U.S. also experience disparities in cardiovascular health, and we need to close those gaps. And so when I was a doctoral student, I remember when I had to, decide on what I wanted to study, I talked to my advisor at that time, Dr. Himmelfarb, and I said, I've looked in the literature and I can't find anything on African immigrants in the US. Like, why is that? And very soon I started making the point that Black populations are not a monolith, right? When you see a person who you may consider a Black person or an African American, we need to acknowledge that there's heterogeneity. So when you look at the slide, the first person is Justice Ketanji Brown Jackson, who is what one would consider an African American. We have VP Kamala Harris, and then the third one, who's that? Anyone? Does anyone want to guess who that is? Yes, Chimamanda Adichie, right? She's a Nigerian but American, and is a prolific writer, right? But in terms of how we conduct research, we lump them all together into one group. So I was really passionate about that, and my advisor said, if you care about it, write about it. So that's what I did. And so this is actually a commentary I developed while I was here at Emory, and it was published about a decade ago, really calling for an evolution in the field and not just lumping populations together in terms of heterogeneity, convenience, right? Because you're masking the heterogeneity in terms of social determinants, cultural differences. And so one of the things I also made a case about was that the size of the foreign-born Black population in the US has increased substantially, and the way in which we conduct research should evolve, right, to reflect some of these changes. So I'll quickly go over the profile of Black immigrants in the US. So in the 90s, there were about 1.5 million Black immigrants in the US, but you can see in 2024, there's been a 221% increase in the size of this population. And this matters. When you look at region of birth, almost half of them are from the African region and the other half are from the Caribbean region. But the increase in the number of African immigrants has been much higher than the Caribbean populations over the past couple of years. And then people think about immigrants, and the point I want to make on this slide is that about 81% hold a secure long-term immigration status, meaning that they are citizens or green card holders. So about 60% of them are Americans. So they are newer Americans. So sometimes there's a tendency to think about immigrants as mostly undocumented, right? So this slide shows that most of them have secure long-term immigration status. And in terms of other demographics, about 34% hold a university degree, which is comparable to the US population. But the point to also know is that they come from different countries. So there's also differences in terms of educational level, English proficiency, 77%. Two things to note, about half are married, which is nearly double the US Black rate. But also home ownership is much less than the US Black population or the non-US Black-born population. So where do these immigrants come from? So these are the top 5 countries of birth: Jamaica #1, Haiti 2, Nigeria 3, Ethiopia 4, and Ghana 5. So these are the top 5 populations of Black immigrants in the United States. And these are data from the Migration Policy Institute. So given what I just said about the growing size of this population, does that match up with what we know and research on this population? I would argue no. And so as a doctoral student, I made it my mission to try to address that gap and advocate for greater investments in research to improve our awareness and knowledge on African immigrants in the US. So as a doctoral student, I was so honored to have an advisor who encouraged me to think outside the box and allowed me to dream big dreams, right? So I said, I'm going to conduct a cross-sectional study and go to churches in the DC metro area and recruit all of these African immigrants. And others thought it was over ambitious, but she said, it is ambitious, but I'm sure you can find the right resources and the right people to help make it happen. So we were able to conduct the study, and we recruited 250 253 people for this study. So in this study, this was, again, conducted almost a decade ago, but we found that 60% had a college education. But this did not translate into higher income, as only about 36% had a household income greater than $50,000. So there's this phenomenon where people come to the US with master's or advanced degrees, but those qualifications are not considered or acknowledged. So you have taxi drivers with master's degrees. So when we think about education as a proxy for social economic status, there might be a challenge or limitation when we just think about things more broadly and don't consider the nuances. And only 52% had health insurance. As we think about access to healthcare, one would imagine you're in the US, you should have access to healthcare, but most people come from countries where you go to the doctor if you're really sick or dying. So the issue of preventive care and investing in health insurance is something that a lot of people did not value. And what did we find? The good news is that only one person smoked out of the sample of 253 people, so not as prevalent, but obesity, hypertension, these are risk factors that were fairly common in this population, would suggest that when we also think about African immigrants, I remember when I looked in the literature and I just searched African immigrants, I saw a lot of studies on what? TB, HIV, AIDS, like, not really cardiovascular conditions, right? So this also suggests that when we think about immigrant populations, we should also think holistically about, risk factors as well. So after conducting this study, a few years later, one of the critiques I got from people was that, well, you only recruited Ghanaian and Nigerian immigrants for that study. They're Africans from different countries. Said, okay, well, we wanted to start small, let's do it again, but this time let's expand the scope, not just cardiovascular conditions, but let's look at the overall health of African immigrants. But this time we recruited African immigrants from 5 countries, again, making it a little broader: Ghana, Nigeria, Sierra Leone, Cameroon, and Liberia. So again, we also wanted to make the point that we didn't want to just say, as long as you're from Africa, you can participate, because what happens, you may have 2 Africans from Namibia and then 100 from Nigeria, right? And in terms of really understanding these nuances, so we said, let's pick 5 countries, and these 5 countries represented the top 5 countries of origin in the US. So that was a justification for selection, not just that because I was from Ghana, right? It was because of their share of the population. So the point I just made earlier about heterogeneity, even in the African immigrant population. So this was a study led by Dr. Bumi Ogumge, who's one of our amazing assistant professors at Johns Hopkins. You can see when you look at the prevalence of hypertension and diabetes, even among African immigrants, there were differences. Liberian immigrants had a higher prevalence of hypertension and diabetes. But in this study, there were associations between social determinants of health and cardiovascular health. So one of the things to take away from the slide is, even when you think about Africa as a continent, and I have to remind people, Africa is a continent, right? Not a country. That there, even within Ghana, there are multiple cultures, multiple languages, but there are ways to do this in a feasible way to really understand how health outcomes or risk factors may differ across populations. So this is another study that we conducted where we looked at the concept of acculturation. So for any of you who may be new to the literature or like work on immigrant health, acculturation just suggests changes that occur when you have a population that, for instance, migrates to the US. And historically, a lot of people thought that, well, when you move to the US over time, you lose all of your culture and you adopt the US culture, right? That's a very simplistic way of looking at things, because in some cases, it's better to hold on to behaviors and cultural values that are health promoting, right? So let's think about acculturation as a concept where there are 2 dimensions. There's the original dimension in terms of where you come from, but also the US dimension as well. So we've published another paper that looked at different acculturation strategies. But in this paper that was led by Dr. Gumbe, we found that people who had actually lived here longer, which is a proxy for acculturation, had a higher odds of being screened for cardiovascular disease risk factors, including lipid screening. Why does that matter? I mentioned earlier that in terms of preventive health behaviors and health-seeking behaviors, for new immigrants, they may not value that, but over time, as they become better immersed in the U.S. culture and are more engaged in the healthcare system, their values or health-seeking behaviors may improve over time. So I also wanted to highlight a systematic review. This was led by a then medical student, Danielle Mensah. And I have to say, Mensah is a very common Ghanaian name, no relation whatsoever. So she's currently a psych, she's a resident now. And so she worked with our lab to look at cardiometabolic health of African immigrants. And then this systematic review, we looked at the burden of risk factors by country of origin in high income countries as well. And the most prevalent risk factors were hypertension, obesity. You can see smoking, and if you're wondering why the prevalence of smoking was so low, culturally, smoking is seen as a socially undesirable behavior, that people who smoke have certain behaviors. So maybe that helps in terms of a lower prevalence of smoking, but in the Afro-cardiac study, like I said, only one participant reported smoking. So when we did this work, a lot of the questions we got was, well, what are you going to do with all of this information? Are you just going to collect data, publish a paper, and then call it a day? And so we said to them that, no, we're going to use these data to really inform grant applications and community-based programs to improve the health of this population. And that's exactly what we did. So I learned that there was a diabetes prevention program. Many of you may be aware of it, DPP. And we said that we don't want to just offer the DPP program as is, but we want to make sure that we culturally adapted and tailored to this population. So the project was designed in 2019, and what happened in 2020? COVID. So we had to pivot, and I'm sure many of you have had to do that during your career. So we pivoted and made it a remote program. Our intention was to have it in person in churches, but we made it a virtual program. And the design was a non-equivalent step wedge design. We said, let's start with a pilot. Let's get 60 participants in 2 African churches in the Baltimore, Washington, D.C. area. Let's look at African immigrants with some of the risk factors, obesity, hypertension, and prediabetes. And let's see if this will work. And so what we did was we recruited a dietitian, a certified diabetes education specialist who was Ghanaian, right? So it was very important to us that the dietitian really understood the diversity of different foods and would not, for instance, recommend meals that, African immigrants would not eat. And she was married to a Nigerian. So the 2 churches were like a Ghanaian and a Nigerian church. So we thought she was perfect. And indeed, she is someone who the participants really enjoyed working with because she understood, the importance of dietary modification, but muted. But she also understood, the cultural differences as well. So like I said, there was a remote monitoring component. All participants got a digital scale. They got a validated home BP device. So there were 2 intervention groups. The first intervention group got the intervention. They got 6 months of a lifestyle intervention with a lifestyle coach, and they did the remote monitoring. And then we waited another 6 months to start with the second intervention group. Ethically, we had an option to offer one group the intervention and the other group nothing. And that was not going to work because we knew the benefits of the DPP program. So we opted for this intervention or this design. So what were our results? So this is a paper that Dr. Gumbe led that was published in JAMA Network Open. Essentially, we found that both groups benefited, right? Like we said, we knew that it would work. And you can see for this paper, the primary outcome was change in systolic blood pressure and diastolic blood pressure. So in both groups, there were significant improvements in blood pressure, and there was no difference between groups, right? Because like I said, one group got the intervention first, the other got it later on. So both groups benefited. So we're working on submitting for a larger grant to do this on a larger scale. So that's work that I've done here in the US. And like I said, when I think about global health, there's a lot we can do to advance health outcomes here. But also because I was born in Ghana, have had the opportunity to receive healthcare in Ghana and our work through the Ghanaian Diaspora Nursing Alliance. We've also learned a lot about, gaps in care and opportunities. So a few years ago, we received a pilot grant from Johns Hopkins to tackle a global health challenge, and we picked hypertension. And so we were awarded a grant, and we did the Adinkra program pilot. So now I'm going to tell you about the Adinkra program, the work that we're doing in Ghana and Nigeria, some of our findings, and how we might all learn from this work. I do want to acknowledge the study team. I mean, this is, of all the slides, this is the one that gives me so much joy because it's in terms of the leadership of the study, there are 3 PIs. I'm one of them. The other 2 PIs are physicians. One of them is a neurologist in Ghana. The other PI is a cardiologist in Nigeria. So for me, it was very important for the study to be co-led by African experts. And so this is the vision of when it comes to leadership of trials on the continent that I advocate for, that I would love to see more of, that there's a lot of talent, there's a lot of expertise on the continent. And so this partnership has been really rewarding, but also collaborating with our amazing colleagues in Ghana, Nigeria, and the US has been tremendously rewarding. And we have students at different levels, pre-docs, postdocs, who are involved in this project. So the goal of the Adinkra program is to test the effect of a multi-level nurse-led mobile enhanced intervention. It's a mouthful. In my overall sort of research interest slide, I told you I was interested in team-based care, I was interested in technology, and I was interested in ways that we can address or advance global health. In the pilot, we did the study in Ghana, but based on the pilot findings, because it was so effective, we expanded the study to Nigeria. And this study is funded by the NHLBI. We had to convince them to fund this work because, again, we are testing a model that could be extended to rural settings in the US as well. So what did we find in the pilot? In the pilot study, just briefly, there were 2 arms, the intervention arm and the enhanced usual care arm. So in the intervention arm, the participants received care from a nurse who was trained. They got a home blood pressure device. They downloaded a mobile health application, and they were able to remotely monitor their blood pressure and get support from a nurse. And in the enhanced usual care arm, they got care as usual from a physician, and we send them daily messages about their health in general. And we wanted to see, is there a difference over time, right? And so you can see on the slide, after 6 months, the intervention arm is the blue section. You can see 57% had blood pressure control compared to 18%. And after 12 months, 80% of those in the intervention arm had controlled blood pressure compared to 24%. And remember what I said about the enhanced usual care arm? It was care as usual rendered by a physician, right? So that's standard of care, but we are calling it enhanced because we just send them daily text messages. So this was exciting to me because I always knew that there's so much that nurses could do, and we're able to show it with the pilot data. So NIH agreed that it was a model that we needed to test on a larger scale. So, and in this randomized control trial, we're using a stepped wedge design and enrolling 800 patients with uncontrolled hypertension in Ghana and Nigeria. We're looking at blood pressure control, but there are other outcomes that we're interested in, secondary outcomes. But again, this is an implementation science project. So apart from just knowing whether this intervention is effective, there are implementation outcomes that we're interested in. How does this work in real world settings? How does implementation look like in Ghana versus Nigeria, right? And even within Ghana, we're doing it in 4 regions, right? And they're not all the same, right? They may have different capacity in terms of the number of nurses that are employed and just the local infrastructure. So there's so much we're going to be learning. We started recruitment only a month ago. And so hopefully in a few years, we'll have some data that shows how well this is working. So in terms of the intervention, I already mentioned in the pilot, we had a mobile health component. We partnered with Medtronic for the pilot, but for the larger scale trial, we're partnering with Omron. So they have a company called Lucy that has a mobile health application that can be downloaded by patients. All participants are also getting a validated blood pressure device, and then the third component is nurse-led team-based care. So And one thing I didn't mention is that in Ghana, we have a unique challenge of having unemployed nurses and midwives. So in the US, we don't have enough nurses and midwives, but in Ghana and other African countries, they're training more nurses than can be hired by the government. So when we think about how to effectively utilize the health workforce, the case that we are also making is that you can train nurses to really specialize in hypertension control. And that's one of the things we're trying to demonstrate. But a new component in terms of our multi-level intervention is a treatment protocol. We tried to do this in the pilot, and we got pushback that nurses cannot really titrate therapy. That is a physician's job. And this is something that was already happening in rural areas. But we were able to make a case for this because there was a trial happening in Nigeria where they trained community health workers. And the community health workers were able to effectively lower blood pressure. So our case was, if community health workers can do it, absolutely, nurses can also do it. So we were able to add that component. So the picture you see here is the kickoff program in Nigeria. Last summer, we had a training. We brought all the teams together. And this picture is a team in Ghana. It was, it's hard to actually describe the feeling of the nurses feeling empowered, coming to learn about what it would take to manage hypertension. We taught them how to measure blood pressure accurately, and it's been really rewarding so far. Now, the last thing I will cover, because more than anything, I really want us to engage in a conversation and also take questions. So this is a study that's been submitted. It's in review. I'm sure all of you, feel the pain in terms of getting grants funded these days. But this is a project that we submitted that is in review that we hope that we can do. It's called Afrobeat. If any of you know the genre of music called Afrobeat, but it stands for Advancing African Immigrants' Cardiovascular, Metabolic, and Kidney Health. So we submitted a proposal where we hope to recruit over 2,000 African immigrants from these 4 countries: Ghana, Kenya, Nigeria, and Ethiopia. And this, if funded, and if we're able to do this, will be the first large-scale longitudinal cohort examining changes in cardiometabolic health of African immigrants in the US. So fingers and toes and all appendages crossed that it gets funded. But I'm also excited because this also allows us to expand our collaboration. So this is the Afrobeat study team. It's a multi-PI project. I'm really looking forward to the opportunity to work with Dr. Foster Ba as one of the investigators on the project. We met, over a long period of time, just thinking through how to really strategize and make this happen. And if this gets funded, we're going to have African immigrants in the Atlanta area that will be enrolled in this trial. So, yeah. So lastly, I just want to touch on, all the people, and this is not a comprehensive list of all the people I had the opportunity to collaborate with, but this is the Global Cardiovascular Health Equity Lab. This is a wonderful team that continues to inspire me. I co-lead this lab with Dr. Bumi Ogungbe, and we have trainees, again, not just nurses, but physicians, not also just at Hopkins, but different institutions. And we are all very passionate about advancing cardiovascular health equity. And I also want to acknowledge my mentors. I'm who I am today because of the wonderful people who have really poured into me over the years. You can see, I'll recognize some of them here: Dr. Himmel Farb, Dr. Lisa Cooper, Dr. Martha Hill, who was the first nurse to be president of the American Heart Association, Dr. Liz Selvin, who's a cardiovascular disease epidemiologist at the Bloomberg School of Public Health, and Dr. Charles Mensah, who mentored me as a doctoral student when I said I was going to address the cardiovascular health of African immigrants. And he lives in the Netherlands and has done a lot of work in Europe. And he agreed to mentor me and has been a great source of inspiration. So with that, I'll say thank you for your time and attention. I'll take questions. Any questions, comments? I also want to be sensitive to people online. So if there are any comments or questions, I'll take them as well.
we do.
That was so amazing. And I feel I known you for a while, but I never seen your trajectory. So this was like very inspiring. Thank you so much for sharing it because I feel like you can tell that it's very personal to you from the story that you're telling. The I have two questions. One, and I have to be honest, I have done very little research or reading on African immigrants, mostly just learned from attending presentations, but I vaguely recall that African immigrants have better health than African Americans. Correct me if that's, or on like very like not adequately analyzed statistics, they often, as a lump sum, tend to do better than African Americans. Is that still the case?
Yeah, so for those online, as she was alluding to sort of this apparent health advantage. So when you look at the literature comparing, let's immigrants to US-born people, there's this tendency to generalize and say, well, immigrants are healthier. But it depends on what you're looking at, and it depends on where they are in the trajectory. So in the Afro cardiac study, the prevalence of obesity that we found, the prevalence of hypertension was actually very comparable to the African American population. Now, granted, that was a small sample. I think there's a danger when we tend to generalize because over time, people may get better in terms of their health or worse, right? There are people who gain weight rapidly. I did when I moved to the US. I gained 30 pounds in 6 months. And there are people who gain it and they maintain that weight gain and develop all of these cardiovascular disease risk factors. But there are also people who, over time, um, as they change their health-seeking behaviors, they get healthier, they get better educated about the importance of, controlling or risk factors of their health may get better over time. So one of our papers that looked at the concept of acculturation, we classified people and we found that people who are bicultural, people who are half and half, where they maintained some of the African culture but adopted some of the American culture, they had better cardiovascular health than people who are traditionalists, people who are mostly like, I'm going to hold on to my African identity culture and not really adopt, any of the U.S. culture. So the simple answer is it's complex, but the most important thing is that it's important to recognize that, awareness of these risk factors may be lower. The prevalence may also depend, but we also need to intervene very early because when people arrive, if they arrive with risk factors and they're not aware over time, their risk for cardiovascular disease may even be higher because last thing I didn't mention is the prevalence of these risk factors has increased dramatically in these countries. So when I say in African countries, so the assumption that people are arriving healthier does not hold anymore because people may be arriving with hypertension, prediabetes, and then their risk may worsen over time.
Okay, thank you. And I guess you sort of answer my follow-up question because I see a lot of parallel with Latin America, and I do research on Latin America, and there's also the immigrant health paradox. And a lot of the reviewers' feedback in proposals or papers is, well, but immigrants are healthier. So I just wanted to hear your thoughts on that, and if you have any recommendations on how to respond to that.
Yes. So this healthy immigrant paradox, the danger is also for immigrant populations. When you think about these cardiovascular events, they often occur when people are older, 50s, 60s onwards. But we also know that a lot of immigrants, as they near retirement or retire, actually move back, right? They move back to their home countries because, again, people want to retire in the countries that they were born in. So we may not be capturing all of those events when they occur after they've moved to those countries. So there's a tendency to say that, oh, well, they are healthier. The other challenge is that we really don't have enough data, right, in terms of cardiovascular events in immigrant populations. I know the Soul study has done a lot in terms of establishing this cohort, but also acknowledging that even in the Hispanic population, there are differences, right? They're not a homogeneous group. So there are some subpopulations that may have a health advantage and there are others who may not. And so it requires that we have a nuanced approach to how we design these studies, but also how we analyze data. Thank you.
I'll ask one question. So doing this large scale international project, specifically in Ghana, one of the misconceptions is technology penetration. How has that been a challenge for you integrating this type of intervention in Ghana, and how have you navigated that?
Yes, so when we designed the pilot, all participants got a smartphone, right? This was an internal Hopkins grant, so we had the resources to do that. And we also wanted to make sure that all participants had a similar phone, and we didn't, if we saw any differences, it wasn't because someone had a specific kind. So they all got smartphones and they all loved it, right? So you're doing a study, you get a home BP device and the phone, they loved it. But for the NIH trial with 800 participants, if we proposed to give everyone a smartphone, that would not have worked, and it didn't work. So we didn't propose that. So to make this model more sustainable, people had to own smartphones. And this is something that we are actually dealing with as we speak, where someone may be eligible based on their blood pressure, values, but then they don't have a smartphone. So it's a limitation that we acknowledge, but the reality is that smartphone penetration is actually relatively high, but it also depends on where you're recruiting people from. So in this study, we are also recruiting people from more rural areas. So one way we've overcome this is we said, if you don't own the smartphone and there's someone in your household, right, who has a smartphone and can download the app, we will also accept you in the trial. And so that way we know that there's a household member who owns a smartphone. As long as we sync it with a device, we can still get the blood pressure values and they would not be excluded. So we started off saying you have to own the smartphone, but we've evolved to the point where it's if a household member has a smartphone, we will take you, right? Because we also want more people to benefit. Yeah, thank you.
You so much for that phenomenal presentation, just highlighting so many really important considerations about partnerships and customization and looking at the nuances, and just so inspired by your work. And thinking about similar interventions, lifestyle interventions for populations in the US, and just the power of community health workers and peer mentors, such an untapped resource in many communities. And so beneficial for so many ways. Wondering if you can just speak just a little bit more. I love that when there was sort of some pushback, like, no, it's just the physicians that are going to be able to impact blood pressure change. But then you said, no, we know nurses can, but we believe also community health workers can. And you demonstrated that very significant difference. If you could just speak a little bit about the training they received and kind of that process and the numbers in terms of ratios of community health workers, and sort of a little more about what their role was with your participants.
Thank you for that question. I didn't get a chance to talk about the Linked BP and Linked Hearts program. So these are two trials that we're conducting in the DC, Maryland area. And that's where we've actually partnered with community health workers. So for Linked BP, they're focused on preventing hypertension. So for people with elevated blood pressure or untreated stage 1 hypertension, we've partnered with community health workers in terms of education, lifestyle modification as well. And in Linked Hearts is a community health worker plus pharmacist. So in Linked Hearts, we're looking at managing people, the management of hypertension in the context of comorbidities such as diabetes and chronic kidney disease. So people who are sicker in terms of having multiple chronic conditions. So we've learned a lot over the past 3 years in that trial in terms of the importance of team-based care. I think one thing we also grapple with is that community health workers are an essential health workforce in terms of really meeting people where they are, addressing social needs when they do arise, but also that partnership between the community health worker and the pharmacist, where the community health worker says something, the pharmacist, when they meet with them, reinforces the importance of medication adherence and lifestyle management. So that partnership has been key. So in those studies, the ratio has been like 30-1, but over time the numbers changed because people were enrolled at different points in time. But I'll be honest, one of the challenges we've had is turnover, right? We've gone through over the past 3 years, we've had a total of about 7 community health workers. That was actually a community health worker we hired. And as we're waiting to start the trial, she found another position. And then we started with another community health worker. And the other thing is that community health workers are not paid enough for the work that they do. So we had a budget that we're working with, but clearly if another opportunity comes up where, you're paid more, they'll, pursue those opportunities. So we've had great people who we've lost, and we've had to train new community health workers. So I think there's so much we need to do in terms of sustainability. For Linked BP and Linked Hearts, the community health workers were hired by the projects, but one of our concerns is when the trials end, which they're about to this year, how do the health systems continue to invest in maintaining those roles? We hope that over the years, we've shown them the value of the roles that the community health workers and the pharmacists are playing in terms of addressing social needs, but helping with medication reconciliation, intensifying treatment. But what would make a difference is if we had policies, right, locally that would allow community health workers to be, gainfully employed and properly compensated for the roles that they play. Thank you.
Thank you for your wonderful presentation. I just wanted to ask, as I just started reviewing my small literature, I am seeing differences between like males and females. I just wanted to find out in your work, has such differences come up?
Yes. So you're asking about any differences in terms of males and females. So in the Afro-cardiac study, we looked at sex differences in the prevalence of risk factors. So hypertension, diabetes, obesity. Obesity was one of the striking differences we found in the Afro-cardiac study, where the prevalence was much, much higher in women than men. Hypertension prevalence, it was the other way around, where men had a higher prevalence. So in terms of trying to understand or explain these, differences, and actually in conversations that we had, so when we conducted the Afro-cardiac study, apart from collecting data, we had an opportunity to educate all participants. So that was actually my role, where we had a team in different stations. And at the last station, they got their report card with all their numbers, and we went over the reality of trying to maintain your health in a new country, right? And working, in some cases, multiple jobs and multiple competing priorities, and childcare, and what does physical activity look like when you're working 2 jobs. So a lot of the women, express challenges. We've done some qualitative work about, the difficulty in terms of promoting or physical activity or maintaining some of these behaviors because of child, care responsibilities and not having enough time to, prioritize their health. And culturally too, a lot of the women convey that women are preferred, how do I put this? In terms of their body shape, there's an ideal, there's a preference for what would be considered attractive, right? So they also worry about losing too much weight and not being, desirable. So there are a lot of, nuances that, in terms of, male versus female. But one thing I'll say is in our trial and in Ghana, when we were recruiting participants, we intentionally, said we're going to use quota sampling to make sure we have enough men and women. If we had allowed participants to be enrolled naturally, we would have ended up with 70% women and 30% men, because men don't typically engage as frequently with primary care as women do, because sometimes when they get pregnant, like there are more reasons for them to engage with the healthcare system. So we intentionally said we want 50% women. So once we hit that target, we stop enrolling women and we purposefully enrolled men as well, because we know that in terms of health seeking behaviors, there are differences. Yeah.
Awesome presentation, amazing work. I want to go back to the way you build your team, because It's just incredible to see the number of people that you're working with. Part A of the question is, how much time do you spend in Ghana for you to be able to get a team like that? And part two of it is, how do you make sure that you get people who are excited about research, people who can execute, and especially also making sure that the nurses are being empowered to be actually on the decision-making table in the process?
Yeah, that's a great question. Speaking to teamwork, right? So the work that we are doing is team science, and right, and how do we value the expertise of our colleagues all over the world and the unique contributions they make. I'll say that we were very fortunate in the Adinkra trial. We partnered with Dr. Fred Stevens Sarfo, who had already received NIH grants. This is someone who had the expertise. He had a team. So it actually made us more competitive when we applied for the R01 because he was an independent clinician scientist, right? And so recognizing that that expertise was there, it made it easier for us to partner because we were not trying to build a new infrastructure. It already existed. And so in terms of teamwork, it requires meeting almost weekly. We have a lot of meetings, meetings for coordinators from each site, meetings for co-investigators and the larger investigative team where we talk through, challenges. When we met in person for the training last year, like I said, it was really empowering. Yes, we had met on Zoom, but all of us being under the same roof, all of us learning together. We had a number of lectures that were delivered by different investigators. So that was, such a wonderful experience because we were all in the same space and learning together, learning about the importance of, teamwork, the importance of accurate blood pressure measurement. It just made it truly, remarkable. Your comment about empowerment. So my vision, and this is something we talked about, is that we're trying to find ways to create ancillary studies that build on the foundation of the Adinkra program. My dream is that by the time we're done, like whatever pilot data we've generated, some of the investigators may use some of those data to serve as what? Preliminary data to continue the work, right? So there was a foundation that already existed. We've built on top of it, but we want each investigator to be better off because of the project. So this involves in terms of like publications, right? Making sure that they have opportunities to be first authors, senior authors. And by the end of the study, like I said, when the study ends, we don't want it to just end there. We want, Adinkra to take different forms. But more than anything, one of the things we've advocated for in our engagement with the Ministry of Health is we want the Ghana and Nigeria to really adopt this model and allow nurses to manage hypertension as part of their scope of practice. That would be a win, right? It's not the paper. For me, if the government can say, yes, your results are credible, this program is valuable, so we are going to really adopt this and train nurses routinely, right, to help manage the burden of hypertension all over the country. For me, that would be a sign of success. That would be one of the most important because I know it will outlive the Adinkra program or any other program that we do.
I'll get to others, but one of the things about the Lillian Carter Center is about scholarship, leadership, and social responsibility. And you kind of just glaze over the GDNA and how you're using that as a vehicle to advance advocacy for nursing. And even you mentioned that about half of the nurses in Ghana are not employed, right? So what is the role of GDNA in advancing nursing in Ghana and across the continent? And how can nurses here at Emory be part of that?
Yeah, great. I didn't get to talk about GDNA because, that's a nonprofit we started about 3 years ago. GDNA is a Ghanaian Diaspora Nursing Alliance. So I talked about diaspora earlier. So how do we build partnerships between, and you don't have to be Ghanaian or African, partnerships between nurses and midwives in Africa and people all over the world. So that's how it started. And we've been very fortunate in the past 3 years to now have over 4,000 members who are from different African countries. We do webinars where we engage experts in different fields who share their expertise to, not just African nurses and midwives. When we have webinars, sometimes we have attendees from Jordan, from all over the world, right, who are learning. One of the things we've done recently is there was a course on research coordination at Hopkins. Hopkins offers this research coordination course. So we were able to negotiate for 6 GDNA members to take that course at a discounted rate, right? And for me, that's meaningful because these are nurses and midwives who are gaining knowledge, but it's more attainable because for a lot of people, cost is a barrier. And so being able to negotiate and make sure that our GDNA nurses can participate and learn, but also share knowledge and impact others' lives is so meaningful. We also have an annual conference in Ghana in January where, again, we bring people from all over the world to come and learn and share. And we also take students. So 2 years in a row, we've taken 10 to 15 students to Ghana to attend the conference, but also participate in our health fair. So really work in partnership and also learn. For me, that's so exciting because there's so much that we can learn from our colleagues all over the world. And I strongly believe in the concept of the principle of reciprocal innovation, right? The innovation or good practice doesn't always come from the north to the south. Like there's so much we can learn from each other. So if you want to learn more, yeah, go to GDNA, g-dna.org to learn more. But we're just getting started, and we're just grateful for the partnerships that we've had so far.
I'm Yujang Kang. Thank you so much for sharing your, very important work. One of the things that I was impressed was that your intervention period was 6 months. And so, what I was so curious, I think it's kind of long, right? When you look at from the participants' standpoint. So, what was your attrition rate, and also, what was your strategy to, have these participants stay in your study?
So, for the Afro-DPP study, we started with 60 participants. By the end of the intervention period, I think we had about 43. So we lost people, but again, like I said, this work was done during COVID. And so 2020 was a very unique time, 2020, 2021, where people were dealing with a lot of different challenges. And so even with the 43 that we had in that pilot who were remaining, we still saw a benefit in those who lost weight. I remember one of the participants, he lost about 30 pounds. And he said he did not know that the diet that he was consuming, the foods that he loved, were making him unhealthier, right? So working with a dietitian, not to cut all, the jollof rice and his favorite foods, but it's moderation, right? Learning about, how to fill your plate with healthier foods, but still enjoy the foods you like. So in terms of retention, one of the strategies we had was we had a WhatsApp group. So for a lot of immigrant groups, WhatsApp is where it's at. So we had a WhatsApp group where we had all the participants, and so we would send reminders and we would encourage them to share any tips, right? Anything that they had done differently. So someone would come up with a creative way of cooking oatmeal and adding different things. So these are all things that help people, feel like they're part of a community. As I mentioned earlier, that the goal was to do it in person, but we pivoted to virtual. But the virtual format actually allowed for a lot of flexibility because if people had challenges with childcare, they could still, learn and participate in the program. But yeah, thank you for that question.
Yeah, I have I don't know if it's a question or a comment. When I was supervising at the Ghana College of Nurses and Midwives, where people go to specialize, I supervised a student who told me she was sponsored. She had some kind of sponsorship from GDNA. So I just wanted to find out or add that maybe if it's possible that these specialists coming from the because she was an emergency nurse specializing, maybe if we involved these specialists coming out as kind of like leaders in this nurse-led interventions, maybe it will have more steam. I don't know what you think about it.
Yeah, so Ibrahim was referring to scholar. One of the things that GDNA has done is award scholarships to nurses who choose to advance their education in terms of specialist programs. So one of our visions, obviously, over time is that if this is a formalized hypertension, specialist program or cardiovascular health specialist program, that we would also continue to support them to get this education, but we're also thinking about ways from taking it from a certificate-based program to a degree granting program, right? Because people enroll in this program for 3 years and end up with a certificate. And we think there's an opportunity to really provide more structure and formalize it. So we hope to continue to do that. But as you're saying, like, we need more champions for nurse-led team-based care, not just for hypertension, for diabetes, for different conditions, because I'll say in Ghana, we only have about 30 cardiologists for a population of 30 million, right? So think about people in rural areas. They're not going to be seen by a cardiologist. In some cases, there are no physicians. So nurses and midwives are not going to replace cardiologists, but we can train them to screen and detect cardiovascular disease. One of the programs we did, Mama CVD through GDNA, is training midwives to detect peripartum cardiomyopathy using an AI-powered ultrasound device, right? So for us, that's an example of, taking a novice nurse or midwife, empowering them with technology, giving them the tool, training them to use it, and if they identify any abnormalities, referring them to a cardiologist who may be in the capital, right, to actually take on the role of managing the condition. So that's the vision we have in terms of, again, we are underutilizing the nursing workforce all over the world. And I think maybe one of the last things I'll say is that we have a unique opportunity with all the resources that we have to think more broadly about uplifting the nursing profession. I think in the US, we've come a very long way in terms of what APRNs can do, full practice authority. That's all wonderful. But it took a lot of hard work, and some of these lessons that we've learned along the way, there are opportunities for schools of nursing to partner in the way that Emory is doing now. And so I was so excited to hear about, the grant that is being awarded and the partnerships that are being forged, because ultimately, in terms of who benefits, it's not just one-sided. It can be mutually beneficial. So just want to advocate for more, schools of nursing to lean into global health, because local health is global health, and local health, it goes both ways, right? So it's about time we stop creating this false dichotomy that, that's global health, something that happens out there, but what happens there affects us all. So thank you so much.
Thank you so much, Yvonne, for such a wonderful presentation, and for all of you and those online for taking the time to be here. We really appreciate you, and we wish you a great afternoon until our next lecture. Bye-bye. Let me stop recording.